So I think that this session may be a bit shorter as well, which will be nice to give you some time to catch up, because I don't know that it'll fill the entire hour, but we can see how we go, and we can discuss things afterwards, and I'm happy to take questions. This is really just about COVID-19 in the face of immunosuppression. Clearly in South Africa, the main form of immunosuppression we need to care about is HIV. So I've spent a bit of time on that in terms of giving you the latest about that. But we will cover just very briefly at the end also cancer and chemotherapy patients and other forms of immunosuppression and what sort of implications they have. There's really two big studies which have happened in South Africa which try and answer the question about whether HIV is a risk factor for severe disease and for death in COVID-19. It's important to put them in context. A lot of the other countries where they've looked at HIV, they haven't seen HIV as a big risk factor, or indeed as any risk factor. So they've really not found a risk association. But I think the big thing in South Africa is the numbers are so much bigger that we can detect even smaller risks. We know for certain HIV is not a very big risk factor for COVID-19 in terms of severe disease or death, because that would be obvious everywhere in the world. But the question, and we mentioned this a bit yesterday, the question is really, is it at all a risk factor? Is it a little bit of a risk factor, or is it no risk factor? And the two studies that were really big in South Africa, that had been done in South Africa, both suggested that it was a small risk factor. So it was a risk factor, but not a huge one. So this is one of the studies. This was done in the Western Cape. I showed you this graph, which you're going to see in the next slide yesterday. But just some more information about it. There's 3.5 million patients, which they included, because it's really just basically the entire of the state system in the Western Cape. And then of those, 22,000 were diagnosed with COVID between the 1st of March and the 9th of June, 2020. So you could see then you had basically those people had COVID, the rest didn't have COVID, so they were the control group. And you could then try and work out what risk factors for COVID there were, and also what risk factors they were for severe disease. This is looking at hospitalization. In fact, this is looking at death, I beg your pardon. And this was the graph I showed you yesterday, where you can see here at the bottom, being HIV positive was a risk factor. So for those of you who are not used to looking at these types of graphs, this is the line here, this red vertical line. It really means no effect. And then anything on the left means that the factor is protective. Anything on the right of the graph means the factor makes it worse. In other words, makes you more likely to die. And then what you see here with each, let's take age 40 to 49, that's the best estimate in that circle, and that's the confidence interval on either side. In other words, that's saying we can be reasonably sure that the true value sits somewhere between that side and that side. So if you look at HIV at the bottom, you can see that it's on the right of that vertical line. In other words, it implies that it is a risk factor for death if you have COVID-19. But you can see it's sitting there somewhere around 2, somewhere from about half maybe to about 2 and a bit as a risk factor. In other words, you're about twice as likely to die if you have HIV and you have COVID, which is not a huge risk factor. It's smaller than, for example, chronic kidney disease or even age 40 to 49. It's very close to just being male. So it's not a particularly big risk factor, but it is there. It doesn't seem to cross that one line. So in other words, we're pretty sure that's the adjusted when they adjusted for as many things as they could to try and account for other rates of comorbidities in HIV patients. The best estimate they could provide was it was about twice, 2.14 times as likely to die. Then the interesting thing about this paper as well is that they could break it down to if you had viral load less than 1,000 versus more than 1,000, and if your CD4 was more than 200. And really what these numbers mean over here is that you can see, if you look at the range here, if your viral load, let's choose this one. If your viral load was less than 1,000, then the risk was there, but you see this confidence interval was quite wide. In other words, it may not even be legitimate. Whereas if your viral load was higher, it seemed to imply quite a lot more risk. This is about 3.5 times, and the confidence interval is pretty convincing there. So it again was one of the first signs to suggest that yes, HIV is a risk factor, but within HIV, it certainly seems a lot worse if your viral load is high and your CD4 is low compared to the alternatives. Then the other study, which is about to be published in Lancet HIV, but it's available as a preprint at the moment, was from the DATCOV database. That's from the NICD, and what they did is they collected all of the admitted patients, so these are hospitalized patients basically, to see whether HIV was a risk factor for for death and for hospitalization, for death at that point. So again, this is a bit of a complicated table, but let me talk you through it. Here's HIV negative people, and compared to, so that they would be as the control group. And if you're HIV positive on ARVs, you had a risk of about 1.3 times of death, whereas if you were not on ARVs, it was nearly 1.9 times higher risk of death. So again, that's telling you a similar sort of picture. People on ARVs do better than people not on ARVs. If you look at CD4 count over here, if you look, here's the reference. So if your CD4 compared to HIV negative people, if your CD4 is more than 200, it was about the same, in fact. You didn't really have any significant change, 0.95. So it's about almost exactly the same risk as if you didn't have HIV. Whereas if your CD4 was low, your risk is about twice as high in terms of death. And then specifically, if you take viral load, similarly, again, a viral load less than 1,000 was a small risk factor. A viral load more than 1,000 was a big risk factor. So it does suggest, again, looking through all of this data, that there is the sort of patients who have HIV that you would expect to have severe disease are exactly the ones who might do. In other words, the people with low CD4s and or high viral loads appear, at least from this data set, to do worse once you're hospitalized. So this is a different study to the first one. The first one was looking at outpatients, for example, and deciding whether or not, or we're looking at everyone, in and outpatients, whereas this study is just looking at inpatients. So it's saying if you're an inpatient and you have a low CD4 and a high viral load, your odds of death are significantly higher than if you don't have HIV. And that's important. But it does suggest, it's not all bad news, it does suggest that if people have their CD4s high and their viral loads low, that the difference then is basically almost none compared to HIV. And that's pretty, HIV negative people, and that's pretty good news, because it's a target to hit. You know, patients who are well controlled with good CD4s don't seem to have any higher risk than those who are HIV negative. So really good data. This will come out in the next few weeks, I think. But this is from the preprint, which is available free for anyone to have a look at the moment. Oh, and somehow I've got one slide overlapping another. Yeah, I'm not sure how that happened. But what I was going to ask is, for those in the audience, do we know where we are with the 90-90-90 targets? Remember, that was by last year. Now we have 95-95-95 targets. But this is how South Africa was doing in 2019. The data was published in 2020. And you can see that in South Africa at the moment, this first 90, we've exceeded. We had exceeded by 2020. In other words, more than 90% of people are aware of their HIV status. The third 90, I'll skip the middle in a second, is of those who are on ARVs, how many of them are virally suppressed? And again, this is exceeding 90% of them. So if you get someone on ARVs, the odds of them being virally suppressed are more than 90%. But it's this middle 90 where we struggle, and many countries struggle similarly. That it's the gap between being aware of the status, but then taking the next step and starting ARV therapy. And this, we only had 75% found. So in other words, that's where we really lost in terms of these 90-90-90 goals. And that's where we are, but that's also telling you, again, for those of you clinicians who see HIV patients, that this is the big missing step, and that's why we so prioritize getting them on ARVs as soon as possible, sometimes even same-day initiations where possible. And this is the big 90 to hit. And this is where South Africa doesn't do well. And many other countries similarly don't do well. And then let me just go to the next one. One other thing to remember, of course, when you're deciding whether HIV is a risk factor, is that it can be very difficult to know whether it's HIV itself that's the risk factor, or whether it's just because many people with HIV have other comorbidities too, which are risk factors. Many people with HIV have TB. Many people have post-TB bronchiectasis, so lung damage following TB. Many people with HIV have COPD. HIV is a risk factor for COPD. If you smoke and have HIV, for example, those are additive risk factors. You're likely to get COPD earlier than if you don't have HIV and smoke the same amount. Many people with HIV have diabetes. And so you can see that HIV itself might just be a marker for severe disease because of these other comorbidities that occur with it. Now, in both of the trials I showed you, they did try and take that into account. And they, for example, could account for TB cases and could account for diabetes and make sure that wasn't the factor. But there's still always possibilities that there are other comorbidities that really are driving this. Nonetheless, HIV does appear to be associated with a higher risk of death, although that risk factor is pretty small. It's not on the par of diabetes or obesity or advanced age. It's a lot smaller than that, and we can all be very grateful for that, because we dodged a bullet, like I said yesterday, Had HIV been a bad risk factor for death, we would have been absolutely in a lot of more trouble than we eventually were in COVID. COVID was bad enough without HIV adding a huge amount to it. So the other component of this, and this is really one of the most important parts of this, this short lecture here, is making sure that the HIV programs run despite COVID, because COVID is very disruptive to public health. You are taking doctors and nurses and all sorts of levels of healthcare workers out of the healthcare system, either because they're sick or they're quarantining, or because they just get diverted into COVID systems. So they get sent from an HIV clinic to help out with COVID in a different clinic or different hospital. And so the staffing goes down. Also, patients struggle to come into healthcare systems. For example, if there's lockdowns with stringent curfews, or like when we had level 5 in the beginning last year, people couldn't leave their houses. So it was, even though you could leave to get medicines, it was still a lot trickier. Many of the public transport systems weren't working as well. So there's a huge threat to HIV. And you can see the implication of that too, because we've shown that HIV, when it's poorly controlled, appears to be significantly worse for COVID outcomes than HIV when it's well controlled. So you really do need to make sure that these HIV services continue as well as they possibly can, because they make a big difference to outcomes, not just in COVID, of course, but to everything else, all the other HIV outcomes. This was a paper that was published this year in Lancet HIV. It looked at COVID-19, the lockdown specifically, on what happened to HIV care across primary healthcare clinics in South Africa. And I want to just show you these graphs. This is the HIV tests per month. This is the ARV initiations. This is the ARV collections. In other words, did patients get their medicines? And this is how many missed visits people had. And you can see here, let me talk you through this graph. So let's do the HIV testing, for example. This just shows, this is starting from 2018, going all the way through to the beginning of 2020, that with time, the average number of tests done each month were increasing. So South Africa was doing more and more HIV testing, which is good. It was helping a lot to diagnose that first 90%, right? Here in the gray is the lockdowns. This is level 5, level 4, level 3. And you can see what happened to the number of HIV tests. As soon as lockdown hit, this shot all the way down. It went from about 45,000 or so tests per month to about just over 20,000. So it halved roughly the number of tests that were happening during lockdown. It did suggest, though, that as time went on, it was improving, although it never got back to the number of tests, at least in this study, that were done before lockdown hit and before COVID hit. Similar patterns with the number of people started on ARVs. It wobbles around, but it was sitting around this sort of solid line number. And you can see this drop off here as soon as COVID started. And as soon as the lockdowns, beg your pardon, started. But it's obviously, it's partly the lockdown, partly just being COVID and people being scared to come to hospital, for example. The number of ARV collections, did people collect their ARVs, was interesting because it did decrease a lot when the lockdown happened. But interestingly, there was quite high numbers just before the lockdown, suggesting that people were maybe coming in a bit early and collecting and sort of building up a bit of a store in anticipation of the lockdown, which is interesting, which is very good. And then the number of missed visits, which we know is obviously a key marker of adherence. You can see here, this was a sort of the numbers were gradually going down with over the years a little bit, but as soon as COVID hit, this number shot up. So many, many, many more people missed their visits. Although fortunately, by about the next month or two, when we hit level 4, a lot more people had started to come back, so they were catching. Since then, some of these numbers have returned close to baseline, but we're still not diagnosing nearly as much HIV or TB either as we were before COVID. And that's a big risk. We're also not starting as many people on ARVs, which is a terrible thing. And those of them who are on ARVs are missing visits and not always collecting their medicines. The COVID puts up a lot of barriers. And it's really important to be aware of that and to try and make sure that while we concentrate on COVID, you don't neglect the other, actually in the long run, probably far more important thing, which is maintaining the population's viral suppression rates. So this was the conclusion from the study, that they say ARV provision was generally maintained through the 2020 lockdown, but the testing and ARV initiations were heavily impacted. And so strategies to increase testing and treatment initiation should be implemented. Easy to say, of course, for them, a lot harder to do in real life, but you need to be aware of that. It is similar, I'm sure Dr. Njeka went through some of the issues yesterday in terms of TB, and very similar sort of stories from the TB world. And those are our two big public health aspects from an infectious diseases perspective, HIV and TB, and both of them took a big knock during COVID. So what advice do we give to those people who are either treating patients with HIV or those people who are, what advice can you give to people who have HIV? And so there's a number of things that were put together, some by the HIV Clinician Society, some through the Department of Health. One thing is, of course, reinforcing prevention measures. So make sure that people are wearing, in fact, cloth masks for the public at least, but obviously healthcare practitioners should be more. Social distancing is important, and especially in the clinics, remember, space people out. Make sure that they're not on top of each other and they don't sit in a long queue in the clinic for hours, all giving each other COVID. Get hand hygiene, making sure it's good. Remember that if it's possible, you could give more than 1 month, and the Department of Health has put out circulars about this too, that you could give more than 1 month's supply, especially if the patient's adherence is good and the patient is doing well and stable, that they don't have to come back every month. You could give multiple months, and that would decrease the number of times the patients have to come back and see people in the clinics, which of course each visit is a risk in terms of transmitting or receiving COVID. And then also prophylaxis, of course, like if you're worried about Bactrim or something like that, if the patient is stable, there's no reason to particularly worry. You could give multiple months. And again, the fewer the times people have to come back, the fewer the chances that they catch COVID or give COVID to someone else. And remember as well that it's not just in the clinic. Each visit entails often, for example, it might be in a taxi ride, which people are very cramped together, and it's difficult to get good ventilation, or they may, the transport there and back is often more dangerous than the actual time in the clinic. So even if your clinic is really well sorted out so that you minimize the chances of catching or giving COVID, you still are asking people to travel, for example, a long time, often in quite confined public spaces. Emphasize clearly the effects of having an undetectable viral load to all the patients who have HIV. So regardless of who's right, whether HIV is a small risk factor or whether a lot of the other international groups suggest HIV is not a risk factor, regardless of who's right, having a suppressed viral load is good for many, many, many reasons. We know this already in HIV, that that's really the key to good HIV health. It may benefit you if you catch if you catch COVID while you have HIV, to have a good viral suppression. And we've shown evidence that supports that. But even if that's not true, you will still need good viral suppression. So it's a good time to remind the patients to be as suppressed as possible. Remember about planning the hospital and the clinic around COVID-19. It requires the same sort of things you would do everywhere in all the public health facilities, such as screening for symptoms before they enter. Try and make as few inpatient visits as possible. So for example, postponing the visits, like we said. Yeah, sorry, yeah.
Yeah, sorry about that. We had lost you. Our system went off a bit.
Oh, sorry, okay. Where did I get up to? Did you see that one?
Yeah, I think this one. Yeah? Can you go back again? One more slide back. Did we see? No? This one? Okay, this one. Okay, the next one, Dr. Jeremy. Yeah, from there.
Okay, sorry.
Sorry. We went off and reconnected. Yeah, sure.
No problem, no problem. Okay, so I was talking here about the prophylaxis and really making sure that both antiretroviral therapy and prophylaxis, if required, is given for as long as possible. And there is a Department of Health circular that's gone out about you providing this, especially in stable, healthy patients. But for example, not requiring people to come in every month is a very useful way to prevent them catching COVID, and a very useful way of preventing them from giving COVID. Clinics like HIV clinics can be very crowded, and that's not good places, even if you try and spread people out in space and in time to try and prevent COVID. Of course, the best way is if the patient's not there in the first place. In other words, if they've got 2 months supply, say, or 3 months supply, and then they don't have to come back in those other 2 or 3 months. So that's a key part of this. And then remember that it's really important to emphasize to the patients again, the importance of having an undetectable viral load. Now, we've shown you evidence from South Africa that the people with an unsuppressed viral load tend to do worse with HIV. There's some international evidence to the contrary that HIV really wasn't a risk factor. But regardless of who's right, and regardless of what the true effect of HIV is on COVID, it's always better to have a suppressed viral load than not, clearly. And we know that from HIV in many, many other settings, that it's the key to good health is having a suppressed viral load in the HIV population. So it's a good opportunity to say that, look, if you catch COVID, it's good to be virally suppressed. So it's another reason to be virally suppressed. And make sure that as many people as possible are in as best health as they can be with the HIV, because that's going to be the key thing that will guide the outcomes. And then I think this is where we rejoin, but I'm going to just do the slide from the top again in case, I'm not sure how much you heard. But like we said, just plan the clinic and the hospital around COVID-19. You're all very familiar with things like screening before entering. So we make sure that patients have a symptom screen. We ask them about that before they're allowed in the facility, so that those who are sick don't sit with those who are not sick. Now, it can be very difficult, of course, because what if you come in and you have symptoms from TB, but then we tell you, no, go and get a COVID test. It's difficult, but as much as possible, those with COVID symptoms obviously shouldn't be around those without. I mentioned about having as few inpatient visits as possible, via postponing the visits or telephonic checkups, even potentially, depending on how your clinic is sorted out. And remember, like I was saying, that it's not just the clinic visit, that each clinic visit adds a risk of giving or getting COVID. It's also the fact that there's many patients are going to have to take public transport to get in and out of your clinics or out of your hospitals. And there may be, for example, in a taxi, which is very overcrowded, may be very difficult to get ventilation that's good. And so the risk often of a visit is not so much when they're in the hospital and sitting next to someone else. It's often just getting there and going back from there in the public transport, which can be very risky in terms of catching COVID. So it's really helpful, as few visits as possible, as long as that's reasonable medically. Obviously, spacing the chairs and spacing the queues, trying not to have all the patients bunched together for long periods of time. Good ventilation is really crucial. Open the doors, open the windows, even in winter. Rather make patients a bit cold than have stuffy air, especially when COVID's going around. Make sure that anyone with respiratory symptoms has masks, surgical masks, and obviously the appropriate PPE, which is covered in this session, in this course rather, for healthcare workers and for those in contact with anyone. So there's lots to do in terms of the HIV clinics. For those who newly diagnosed with ARVs, remember, we want you to be on ARVs as soon as possible. Two reasons to emphasize this. One is that, like I said, that is where South Africa struggles in general, that gap between diagnosis and starting. So even same-day initiation, depending on your clinic's setup, may be feasible. And again, the quicker you start, the fewer visits they have in between, the less the contact with the healthcare system. There's no evidence of COVID iris, so we're not worried about if you've got COVID now and we give you ARVs, is it going to worsen your COVID? No evidence of that at all. So you don't need to worry about that. And again, the sooner people are on ARVs, the more they are likely to be protected if they catch COVID later. Make sure that vaccinations are up to date. So this is the influenza vaccine, which is available via the state sector for HIV positive patients. Pneumococcal vaccine is not in the state sector guidelines for HIV patients. If the patients are in private or if they have the money, they could get pneumococcal vaccines. These are for HIV mostly, but again, it's just a good idea. I've seen just today 2 cases with pneumococcus, which is Streptococcus pneumoniae, and COVID together. Clearly that's bad. It's better if you don't have both together. So that's part of it, but really the influenza vaccine by the state sector is a good thing to keep up with. Fortunately, we haven't had a lot of influenza. Last year we had almost none, and this year we're having very low amounts. And the reasons for that are largely because everything is so well set up to prevent respiratory viruses now. People are washing their hands, people are distancing themselves socially, people are wearing masks. So all the things that work for COVID actually, it turns out, work for influenza pretty well too. And so the rates of influenza are much lower than we would normally be expecting. Nonetheless, if you can get the vaccine, still a good idea. And then I wanted to just open up to the audience at this point and to ask you what you think of this case. So this is a 34-year-old male. He comes into casualty. He's got HIV. He's known with HIV, but we don't know his CD4. He complains of shortness of breath, cough, and fever. He's distressed. His room air saturations are 77% on room air without oxygen. How would you treat him? And I'm going to just, perhaps one of the facilitators could just pick someone, or if someone wants to volunteer, and they can just shout out what you would do.
Thank you for giving me the powers. Okay, do we have a volunteer? Someone who wants to come up and just give it a try? Yes, you can just come up front, and so that Dr. Jeremy can also hear you. Also, if you think you will add, you can come. Yeah, You'll be here so that you manage time. Yeah. Right.
Oh, speaking to us.
Yeah, you can speak to him. I'll have the mic.
Hello.
Hi.
It would be nice if we had the CD4 count, but in terms of differentials, then it would be COVID high up on the list, but can't forget about PJP at the same time. So we'd probably have to put him on oxygen given the situation, start him on the COVID protocol, cover him with Bactrim, just in case there is PJP infection.
That is the absolutely perfect answer. So what I wanted to make sure, because it's a bugbear of mine, is that in this COVID epidemic, when you see an X-ray that looks like it could be COVID, and this X-ray could well be COVID, remember it's got these bilateral, roughly symmetrical infiltrates, kind of soft interstitial infiltrates with a more involvement of the mid to lower zones than the upper zones. This is the same X-ray I showed you yesterday. Please do not forget about PJP, because we forget in any other setting before COVID started, when you knew this patient had HIV and they walked through the door and they had an X-ray like this and the SATs that bad, you would absolutely give them PJP treatment. And that's an absolutely key point. Please don't forget about it, and please treat empirically. And I'll show you next, because we don't want people dying of PJP just because we happen to be in a COVID epidemic. And they can be very difficult to tell apart. So well done, that's the perfect answer. That's exactly what I was hoping people would say, and hopefully not fall into the trap of just saying I've managed the COVID. This could easily be PJP. Now, both of them can present with hypoxemia, both of them can present with infiltrates on X-ray, with fever. It can be very difficult to tell them apart. So we need urgent HIV testing for anyone who comes in with suspected COVID, because if you do a rapid test and they're positive, then PJP becomes a very strong likelihood as well. If they're known with HIV, then that's again a helpful thing. But I've got some pointers on the next slide, which are some ways to try and distinguish the two, at least mostly. But if you're not sure, treat for both. You know, if the patient has HIV and you're not sure if the CD4, if the CD4 is low enough, and they have this kind of clinical picture, treat for both, at least initially. If the result comes back positive now they've got COVID, then you can de-escalate the other one. You can stop the Bactrim, usually. So these are some of the ways that you can tell. Exactly as you said, because I didn't give you a CD4 deliberately, and you rightly pointed out, it's a pity we didn't have a CD4. That's because the CD4 more than 200 makes PJP pretty unlikely. Yeah, if it's 210, I wouldn't rule it out. But if it's 400 or 350 or something significantly more than 200, it pretty much says it's not PJP. Now, it's not absolute, yes, there can be other risk factors, but for all intents and purposes, it's a pretty good rule out value. Obviously, that CD4 must be recent. It doesn't help to look at last year's CD4 in deciding, but that's a pretty good way. Someone who's on Bactrim prophylaxis, this is all, in other words, with an HIV patient who could have either COVID or PJP. Someone who comes in with on Bactrim is pretty unlikely to have PJP. The Bactrim works really well at preventing PJP, as long as they've been on it, not just for a week or two, as long as they've been on it for a month or more. That makes PJP pretty unlikely. Obviously, you've got to be sure they're taking it. It doesn't help to just prescribe it if they're defaulting or something like that. But if you're sure that they're taking it and you're pretty convinced, then it makes pneumocystis pretty unlikely. For those of you in a hospitalized setting who can do slightly more testing, beta-D glucan is useful. If it's significantly raised, it does make PJP much more likely. But you can have many false positives, so it's not a very useful test. And then for those of you, like I said, in a hospital setting who can send off for pneumocystis testing on the sputum, clearly if it's positive, that makes pneumocystis very much more likely, so PJP much more likely. But again, it can be negative. A negative result doesn't help you here because it's actually a very insensitive test. So those, if you send off for PJP on sputum and it comes back negative, it doesn't mean it's not PJP. It's only helpful if it's positive. And beta-D glucan is the opposite. It helps most if it's negative because it rules out PJP pretty much. But again, those last two may only be available in hospital settings. Certainly wouldn't advise it at a clinic level. But at a clinic level, you can look at those top two and make sense of the likelihood. If you're not sure if it could be both, or if you just don't have the data, please rather treat for both initially. And then once you get the results indicating one or the other, you could stop the other treatment. So if you get a COVID result, I think it's pretty likely you just have COVID and not pneumocystis. You could stop the Bactrim. If you get a positive result on the pneumocystis, you could put, and a negative result on the COVID, you could stop the COVID treatment. But really, really, really important. It's the #1 differential that looks like COVID. in the HIV population. So well done, and make sure you remember that, everyone else in the room. Don't miss PJP. Don't want people dying unnecessarily. In the appropriate context, for example, so say the CD4 is less than 200, he's not been on Bactrim prophylaxis and the chest x-ray looks good, just give both. Like we said, give treatment Bactrim with steroids. We're using the steroids anyway for COVID. So, and you could give the dose of Bactrim, which is actually higher dose steroids than for COVID, but that's fine. You'd give the Bactrim, the PJP dose of steroids is fine, but as long as you're giving the Bactrim in that setting, that's great. And then very briefly to end off, like I said, just a couple of slides in terms of COVID and cancer. And so one thing is to understand that, yes, as expected, having cancer is worse in terms of your risk of severe disease. There was lots of studies. I've just quoted one number here, which is from a meta-analysis, which showed that if you had cancer, active cancer, your risk of severe disease was 1.7 times, which is really saying you had 70% increased risk of severe disease. Of death, I beg your pardon, sorry, not of severe disease, if you get COVID. So in other words, having cancer and having COVID at the same time is clearly not a good thing. It's not unexpected. That's what you would have thought, but there is evidence to support that. Interestingly, not all cancers are equal. The ones which are particularly bad are the hematological cancers, so lymphomas, leukemias, and the like. You tend to do quite a lot worse with, just because, remember, they are involving your immune system directly. You may have no T lymphocytes, say, at all because of chemotherapy or just because of marrow infiltration, and your antibody production may be much less. So the hematological malignancies are the worst in terms of risk. Solid organ malignancies like breast cancer and lung cancer that are a lot less of a problem, but they are still a risk for severe disease. So not unexpected, but the evidence does support that. What about a previous history of cancer? It's unclear from the evidence. There's not a lot of evidence either way, but I would be surprised if a previous history of cancer that's more, that's pretty remote, let's say 5 years or more ago, and that you're not suffering any current problems from that cancer, I would be surprised if that was a risk factor. So I think you're okay if your cancer's under control and you're fully treated and you're not on immunosuppressives or any chemotherapy drugs or anything like that. But it is largely unclear. Clearly, all of these patients need to take extra precautions about their COVID. So they need to avoid crowds. So if you, for example, if someone with cancer says to you, Doc, what can I do to prevent COVID? Well, we'll come to the big one in a second, but there's all the other slightly more boring things are actually very, very effective. So avoiding big crowds, you've got to say, listen, you in the middle of chemotherapy, do not go and hit up big gatherings. Don't, even if that means don't go to church, don't go to parties, don't go to family events. It's really your risk of catching COVID in big events with lots of people is exponentially higher than your risk in small numbers of people. Avoid poorly ventilated spaces, clearly wear a mask as much as you can. So all of these things, the same things we all know how to prevent COVID, apply to those with COVID with cancer. And you just got to reinforce it to those patients that they need to be even better than normal at it. So we're really avoiding the crowds, avoiding poorly ventilated spaces, etc. You need to pay special attention to drug-drug interactions between whatever they're on for their cancers and whatever they're on for COVID. So for example, if you give steroids for COVID, let's say, and the patient's on a chemotherapy regimen, you've got to be a bit careful of that and discuss maybe with their oncologist. It's not to say the steroid shouldn't be given, just that it may be necessary to run that past the oncologist if possible first. And or just make sure some of the things like azithromycin, which remember we don't recommend for COVID in South Africa, but it sometimes gets given or it may be given empirically before you know it's COVID. Those sort of drugs can interact with chemotherapy drugs and from other drugs that they may be on for their cancer. So just be aware if you have COVID and cancer to check the drugs and make sure there's no interactions. There's online free drug-drug interaction checkers, but otherwise just discuss with whoever their doctor is for their cancer. And remember that if you, for example, need to have chemotherapy as a patient, when should you time it? Well, here it becomes tricky because clearly in an ideal world, if you could, let's say you had the option of giving chemo now or in a month's time or 2 weeks time, let's say, clearly it's a better idea to give it in 2 weeks time because the COVID numbers are all coming down now. In other words, in 2 weeks time, the risk when you're immunosuppressed will be a lot less than it is now. But in many cases, you just don't get that luxury. You're not able to choose the timing because the patient needs chemotherapy now. They can't wait a month. But if it is possible to delay, some people, for example, in the maintenance phases when they're in remission, may be able to delay getting subsequent chemotherapy doses by a little bit. And so obviously you could try and time it to avoid the big parts of a wave, but in many cases it's just not possible. And then the big way, of course, to prevent COVID with anyone who's immunosuppressed is to get vaccinated. One of the most common questions is someone who is fragile, like they will say, I've got cancer, I'm on chemotherapy, I've got some immunosuppressive drugs. Is it safe to get the vaccine? And it's really, really crucial point that you all be aware of is that being immunosuppressed is not a risk factor in terms of getting vaccinated. There's no reason not to take them. Now, that's not true of every vaccine. For example, if you are getting a live vaccine, like a measles vaccine or a varicella vaccine, like the ones we have in South Africa, people who are very immunosuppressed should not get those vaccines because they are live organisms, even though they're attenuated. And if you're very immunosuppressed, it's bad. Remember, none of the COVID vaccines that are available are live vaccines. That does not apply. All of the COVID vaccines are safe, no matter how immunosuppressed you are. And that's an absolutely crucial message to get out to anyone who's on the fence about this. And more than that, of course, the people who are immunosuppressed are exactly the people who do need the vaccine because they're at higher risk of severe disease. So it's not only just that they're very safe, and in fact, there's no reason to worry about immunosuppressed patients with vaccines at all. It's more that they should be the front of the queue to get these vaccines because they are at higher risk if they catch COVID. And I've shown you that evidence on the previous slide. So really, really, really need to push people with any form of immunosuppression to get these vaccinated. The one problem with them a little bit is that, as you might expect, because you depend on your immune system to develop protection from a vaccine, is that people who are immunosuppressed, in those patients, the vaccines may not work quite as well. So be clear what I'm saying here. It's not saying you shouldn't get it. No, you should get it. And it's not saying there's any safety problems. No, there's no safety problems with immunosuppressed people. But what it's saying is, despite getting it, you might still not be quite as well protected as those who don't have immunosuppression. We've seen this in a couple of the trials, for example, the Novavax trial, where the HIV patients did a little bit worse, although again, so few of them that it's very hard to tell. And we've seen it certainly in overseas with chemotherapy patients and those with hematological malignancies. They don't seem to mount as good a response to the vaccines. And certain overseas countries where they've got plenty of vaccine, they're actually advocating an extra dose. So like if you're on a Pfizer, taking a third dose for these patients. That's not the case in South Africa at the moment. It's not part of the national policy. It may become one with future. So for example, once we vaccinated everyone with at least the first way who want it, it may be that the program decides to circle back and saying, if you're immunosuppressed, maybe come in for an extra dose. That's very speculative. That's not what the program is saying at the moment. I'm just alerting you because that is one aspect. If they say, will the vaccine work when I'm immunosuppressed? I think the honest answer would be that yes, it will give some protection, although that protection may be a bit less than if you were not immunosuppressed. But that's not a reason not to get the vaccine. That's a reason to get the vaccine. And we know that the vaccines are all very good at preventing severe disease. So the more people who get vaccinated, the better. I think that's it, more or less, from me. Yeah, that is that. So I'm happy to take questions, but I just want to summarize again what we went through. So we went through HIV mostly, and we spent time on HIV. And the key things there is that although it's controversial, I think that in the South African context, it does appear that HIV is a minor risk factor for severe disease and for death with COVID. And fortunately, though, within the HIV pool, it appears that if you have a good CD4 and a suppressed viral load, that you probably have a rate of severe disease and death, which is as if you were HIV negative. So really, if anything, is being driven by people with low CD4s and unsuppressed viral loads. So that's good in the sense that it's modifiable. If you get people's viral load suppressed and the CD4s up, you help protect them against COVID. It is controversial. There are other studies which did not find an association with HIV and severe disease, but I'm showing you the two big ones in South Africa mostly. Then we talked about the key implication of HIV on the healthcare system being that COVID on the healthcare system, COVID disrupts the HIV program and we get less tests, less people started on HIV, more people missing their visits and not collecting their meds. And we need to do whatever we can to mitigate that, because that's going to be a long-term, far bigger problem, I think, if people are becoming resistant because they're off their meds. And then we talked about some ways which you can structure your clinic and your visit scheduling to make sure that people have as little chance as possible of catching COVID in your HIV clinics or as giving COVID to other people in the HIV clinics. And then we just briefly talked about the other forms of immunosuppression, such as people on immunosuppressant drugs, people with cancers and malignancies, and more or less exactly as you'd expect. It is also a minor risk factor for severe disease, similar to HIV. But the key things there are that they need to be very diligent about the non-pharmaceutical interventions like washing hands, social distancing, wearing masks, etc. And they also need to get themselves vaccinated ASAP if they haven't already. The vaccines may work a bit less well compared to a non-immunosuppressed person, but they are very safe and they are important ways to prevent disease. People with immunosuppressed conditions should be at the front of the queues to get the vaccines. So as much as you're able to advocate for that, you should do so. And I'm going to leave it there. Again, I'm happy to take questions on any of these aspects. Thank you very much, Lesego and others.
Thank you very much, Jeremy. Can I see by show of hands, please come this side? Yes, I think there's a number of questions. So let's get the first one and then we take it from there.
Okay, thank you, Doc, again for a wonderful presentation. I've got perhaps a stupid question, but it's something I've been thinking about a lot. You spoke about those that are highest risk, that they should get vaccinated and self-isolate and be very careful. Now, I've got colleagues. I had a colleague who didn't see his folks the whole of 2020. He didn't visit them once because he was concerned about COVID and spreading COVID. And I've got another colleague who's got terminal cancer, who also has so little visitors. So I wanted to know, is there anything we can tell these people that, like, they've been separated from their family members for so long, they desperately want to visit? Is there any precautions they can take, or should we tell them rather to just keep their distance? It's a difficult question, I know, but what should we tell these people that are desperate to see their families and haven't seen them for so long, but are concerned about giving them COVID?
Yeah, it's such a good question. And I'm actually on one almost extreme of this, that I think we need to try and normalize things as soon as possible, but it requires vaccination, really, unfortunately. The vaccinations are the way to break the link between caseload, which I think will always have this virus around for years at least, and severe disease. And the vaccines break that link so that even if you have a lot of cases, if everyone's vaccinated, the chances of severe disease are so much lower. So in terms of, for example, someone who's got cancer or on the other side, someone who doesn't want to go and visit someone who's immunosuppressed or elderly, I think it has to be an individualized decision, but I think there's ways around that. So for example, I'll give you an example. My grandfather's 90 years old. He is hiding himself away for the first year, basically, to avoid catching COVID. But he's very keen to see everyone from the family. So this is what we do. We say, here's the precautions we take. He's vaccinated, I'm vaccinated, which is a big help. And then what we do is we say, for example, we're not going to have big events. We're not going to have the whole family around at once, but I'll go and maybe me and my brothers will go and visit. So there's 2 or 3 of us, and we'll go and we'll say hi and we'll stay with them for a couple of days. And then the visit is smaller, the number of people around are smaller. He's vaccinated, I'm vaccinated. Obviously, no one is symptomatic. If we're symptomatic, we wouldn't do it. But yeah, life has to get back to normal. I mean, at some point, at least something close to normal. Because if this virus doesn't go away, and my opinion is it won't, then what you're left with is making sure that you take as many precautions as you can and just being sensible as you can and making individualized decisions. So, I mean, I think it would be terrible, for example, not to see his family for a year. And I think, especially if they're vaccinated and he's vaccinated, I think the risk of anything bad happening, especially in a small group, is very low. And I think, again, is the risk zero? No. But is the risk acceptable? Well, that's an individual choice. But in many cases, the answer will be yes. I think it is an acceptable risk. And again, it's going to have to be individualized. In many cases, this reminds me a lot of the discussions, because a lot of my life is HIV related. And in terms of looking after patients with HIV, and many times this reminds me of being phoned about needle stick injuries, because someone will say, well, I don't think I got any blood in the eye. I mean, I didn't see anything, and I don't, check myself. I didn't draw any blood or anything, but do I need to take HIV? And what they're post-exposure prophylaxis, and what they're really wanting is someone like me to say the risk is zero, you don't have to take it. But of course, that's never the case. So all you can do is say, look, the risk is very, very low in these low risk scenarios. I would, or if it were me, I would or wouldn't take it, but it's up to you. And I think that's kind of a model for what to do in these cases. I'm answering a very long-winded answer, I know, but it's a very difficult topic. I think, though, vaccines change the dynamic a lot. I think if everyone in the group is vaccinated, the chances of anyone getting severe disease from a transmission there are so low. And I think that, again, you know, you're obviously going to titrate it. If you're meeting a 40-year-old, you might tolerate bigger groups than if you're meeting a 90-year-old. But while it's individualized, vaccines have to get you somewhere close to normality, at least when you're outside of a wave, and at least when the majority of people are vaccinated. And that's my answer for now, but it's complicated, I think, and it's difficult.
All right, thank you, Doc. The next question, I'll hold it for you.
Okay, you said the diagnosis of TB and HIV has dropped, and you said that brings a bit of worry on your side. Is this not just a benefit of a drop in the use of alcohol and the nightlife associated with it? I assume in such contacts, during people being drunk and the nightlife partying, there's increased the risk of spread of both HIV and TB. So what we are seeing in the clinic, not getting HIV and TB being diagnosed, is it not a benefit of the long lockdown which we had in 2020?
Yeah, that's such a good point. And I think there's some truth to that in the sense that, for example, some of the decreased TB diagnoses may be because the ventilation in general is better. People are social distancing. Remember that some of the ways that you catch TB are the same as you catch COVID. And so it's not necessarily the lockdown specifically, but it's all the measures we put in place for COVID might well have some beneficial effects on TB, at least partially. So I think that's part of the truth, but I don't think it's all, sadly, because if you see those graphs, they drop down immediately as the lockdown started. And remember, we're not, you know, so in other words, people who needed ARVs, they would have caught their HIV long before the lockdown, but what was happening is they weren't getting started on ARVs. And that change was so immediate when the lockdown started that it suggests it really was mostly artificial. It wasn't that we had fewer HIV cases. It was just that we weren't able to access them during the lockdown. And it's not just the lockdown. It's not just saying you can't leave your house from certain hours. It's also the fear of patients coming in to healthcare systems. Lots of patients didn't want to come into hospitals because they knew that COVID was there. So the short answer is, I think that what you say has some merit and it's got some truth to it. I agree. But I don't think it's all of it. I think that there is a lot of healthcare system strain and dysfunction that occurred because of COVID. And that is unfortunately, you know, it does lead to slightly worse HIV outcomes, unfortunately. So it's a bit of both, I think.
All right, thanks, Doc. Two more questions. I'm going to ask that maybe we take both, and then after that you can reply. Thanks.
Sure.
Thank you, Dr. Neil, for the wonderful presentation. I just taking my chance to ask a question. Do you have any information about the mortality rate in South Africa in COVID patients ventilated, more or less a comparison between maybe the 1, 2, and 3rd wave?
Okay, you can take the second question.
Yeah, thank you, Doc. I've got another question. I've had a few very strange presentations of COVID. I've had a HIV positive lady who presented with a spontaneous pneumothorax that we swabbed by accident and then came back COVID positive. And we've had quite a few patients who were supposed to go to theater and then they swabbed them before, and then they come back positive even though they were asymptomatic. So I wanted to know, can an argument be made that we should be swabbing all hospital admissions or swabbing more people? And because it seems like a lot of asymptomatic patients with strange presentations are hiding in the population.
Yeah, yeah. So let me take the first of the question. So I'm just going to pull up the other thing while we talk about it. So for mortality and ventilators, so I don't know off the top of my head, it's high, and the mortality actually, I can tell you, I mean, you know, so once you ventilate it, the mortality is well above 50% in most cohorts. In many cohorts, it's well above 70, 80%. So the patients don't do well on vents. It's not to say you shouldn't ventilate them because they would do even worse if you didn't, but it's clearly not a game changer. You know, if you're that severe, the chances of death are quite high. In terms of comparisons between the first, second, and third waves, I don't know specifically for ventilated patients, but I do know that the mortality rate for hospitalized patients came down between the first and second waves. Most probably it's a mixture of reasons for that. for example, much more widespread use of steroids, which wasn't true of the first wave because we just didn't know it worked yet. It wasn't in the guidelines. So steroids, and then also people getting better and more used to it. So the systems were better. Some of the healthcare practitioners were more proficient at knowing what to look for in COVID. And the flow between clinics and hospitals was a bit better. So people got better and more used to treating people with COVID, and the mortality went down. But also we got some new drugs, mostly steroids, which helped a bit. So I think mortality is going down as a percentage of cases, but the third wave, we don't know yet. The data's not in, and our worry, like in Gauteng, where we got pretty much overwhelmed by COVID, the mortality may be so much higher, not because COVID was worse, but just because we couldn't cope with the numbers. Anyway, so we'll have to see for the third wave. And then in terms of who to test, so yeah, it's not an uncommon scenario, as you say, that you test people, say, pre-theater and then totally asymptomatic and they come positive. And that's clearly at risk during a big wave, because when there's a big wave, all sorts of people get infected unexpectedly. And remember, COVID can be totally asymptomatic, as you said. So the Department of Health does have guidelines about who to test. And one of the groups that they recommend testing on is, in fact, all hospitalized patients, whether they're symptomatic or not. So outpatients who have symptoms need therapy, need testing. People who are close contacts need testing. But for hospitalized patients, if your health system can accommodate it, because it's often quite onerous to do, but it is actually recommended to test every hospitalized patient, whether or not they have symptoms. But obviously prioritize those with symptoms so that the results are received within 24 hours. That's the Department of Health guidance. So yeah, I would test everyone if you can, but obviously if you can't, you're going to prioritize the symptomatic ones. Thanks.
All right, a small one from me, Doc. Is there something called COVID iris on a lighter note?
It's a really good question. No, not as far as we know. So we've not seen like you're talking about in the HIV patients. If we start them on ARVs, they don't seem to iris. There's lots of post-inflammatory things COVID does, but it's not technically an iris, no.
All right. No, thank you very much. That's all the questions we had.
Great. Thanks very much. Thanks for having me.
Okay, thank you.
All right, thank you so much, Dr. Jeremy, and it was a pleasure to have you, and we'll still engage you for the other provinces as well. And I'm sure the participants have really enjoyed the sessions and looking forward to having more with you. Thank you.
Great, thank you. It was a pleasure.
Thank you. All the best.